Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
So this is going to be kind of just a little bit of a brief overview in terms of just how we conceptualize depression in folks living with HIV, but also kind of a treatment algorithm approach that I talk to a lot of our psychiatry residents, but also our internal medicine residents about. I don't have any conflicts or relationships to disclose. We'll talk a little bit about some disparities, but in this, it's just a limited perspective about how systemic, social, and economic factors impact health. We know that racism and not race itself creates and perpetuates health disparities. Brief overview, we're going to talk a little bit about the burden of depression in people with HIV, talk a little bit about screening for HIV in the primary care setting, and then kind of go into a little bit on the general treatment algorithm, that the way I kind of view it, as well as just the evidence-based approach to the treatment of depression. So depression is the most common psychiatric comorbidity among people with HIV. Its prevalence is 3 times greater than that of the general population. In the past month, depression ranges between 21 and 25%. And we know that people living with HIV, not only do they have higher rates of depression, they also have higher severity scores of depression when they are suffering from it. So depression is really important that we treat in HIV care, especially. We know that untreated depression lowers our adherence to antiretrovirals. It's twice as likely to be non-adherent than our non-depressed people with HIV. There's an increased odds of dropping out of care, and then the length of depressive episodes increases risk of losing viral suppression. So there's a direct correlation between the length of the depression episode and the risk of being inadherent to medications and becoming non-virally suppressed. So when we think about depression in primary care settings, I think most people are kind of thinking about this in terms of how do we think about it from a population standpoint, how do we capture this? And a lot of folks are using the screeners. I know our clinics here are using screeners for folks. Kind of the most common one is the PHQ-2 as kind of our just general screener, and then that's a triggered screener that then kind of goes into the PHQ-9. And that's kind of considered a good practice these days, is most people being monitored with the PHQ-2 kind of at any random interval. We don't actually have a good testing interval to be able to say this is the appropriate amount of testing, and the U.S. Preventative Task Force actually doesn't tell you how often we should screen, only that we should be screening. I will say my own personal primary care doc, every time I go see them, I get a PHQ-9 and fill it out. I think that that's a reasonable screening frequency, but I think it's based on kind of your own availability, your own ability to kind of then act on the data from it. So the PHQ-2 is really just the first 2 items of the PHQ-9. It's the 2 cardinal symptoms of depression. And then the rest of it is then kind of more fleshing out understanding it. PHQ-9 has been validated in pretty much every health setting, from psychiatric clinics to HIV clinics to inpatient, outpatient, all kinds of medical settings. It's a 4-point Likert scale, so it goes from 0 to 3, not at all, to very severe. And it's a patient self-report, so it's a pretty easy thing to fill out. Another scale that could be reasonable to utilize, I think a lot of folks will do it in kind of specialty geriatric clinics or geriatric psychiatry clinics, is this geriatric depression scale. There's 2 forms. There's the GDS-30 and the GDS-15. The GDS-15 is a 15-item question. It is validated in adults 65 and older, and it's been validated in patients with HIV, so that's great. I actually like this in both the Geri setting, but also in particular our Geri folks who are living with HIV, because it's a little bit less focused on some of the somatic symptoms than the PHQ-9 or some of the other screeners that are available out there. And the reason why I like that is that, as we'll see kind of as we go forward, a lot of the depressive symptoms that are somatic in nature, meaning fatigue, sleep disturbance, they're already highly comorbid in patients who have HIV. So sometimes you may be overestimating some of the severity of the depression simply because you're picking up on some of the organic symptoms of the virus and not necessarily depression itself. The geriatric depression scale is also a little bit more sensitive and a little bit more specific, so it's going to pick up more people. Again, it is really only validated in adults over 65, so that's a big one. And then another really big one is it lacks the suicidality question. So BHQ-9, item 9 on it is is asking about suicidal ideations. The geriatric depression scale does not ask that. I'm not sure why. It seems like a really easy thing to do, but it's been out for 40 years. Probably not going to change it at this point. It's also a lot easier for folks to fill out. It's just simple yes/no questions. I know some people will fill out the PHQ-9, and a lot of people they don't like that forced choice of where is it between a 1 and a 2. And I have several patients that kind of borderline and they'll always like of 2 and 3, and they just always circle in the middle. It's a good point of what happens when someone kind of circles it in the middle. The PHQ actually says go with the highest part. So if someone's like circles in between 1 and 2, that's actually just a 2. And again, the geriatric depression scale, it's the self-reported scale. So this is the questions from the PHQ-9. So it's asking about how many days that these symptoms are actually bothering you. And so that's really important for us to think about, especially in the cardinal symptoms. So 1 and 2, the little interest, pleasure in doing things. So that's anhedonia, which is a hallmark symptom of depression, as well as like feeling down, depressed, or hopeless, which is our self-report feeling of depression. Either one or both of those have to be positive for you to be able to diagnose someone with a major depressive episode. And then the rest of it is then you have to have 3 or 4 other symptoms, depending on if they've chose one or on it. And again, the more days that people are feeling this, the more severe it is. We'll talk a little bit more about this as we go forward. GDS, with the geriatric depression scale, again, it's 15 items. It's pretty easy. It's yes, no. I will say one thing from a psychometric design standpoint, having flipped scores is harder for you as a clinician to score, but it's actually better from a content validity standpoint because it prevents people from being able to just like straight yes all over. So it is actually going to be a more accurate, which is one reason why it has a little bit higher sensitivity and specificity. So personally, from a research standpoint, I actually like the GDS simply because it kind of forces you to read each question and not just go down the list. So there are cutoff scores in this. So when we're thinking about people's scores, it's important to kind of look at this. So the PHQ-9 goes kind of a wonky. It goes no depression, mild depression, moderate, severe depression, and then severe depression. The DSM-5 only recognizes mild, moderate, and severe. So what do you do with moderate, severe depression? You still classify it as a severe depressive episode in that case. So it's kind of like severity 1, severity 2 for it. The GDS-15, it's more consistent with the DSM-5, so it does no depression, mild, moderate, severe. These are only indicative of depression. This isn't necessarily the diagnosis of depression. You as the clinician still have to make the diagnosis. You still have to use your clinical judgment for that to be able to say this is or isn't. And there are times where the PHQ-9 and I disagree when I see a patient. So for example, 0 to 4 means no depression. However, if you report a 3 on item 1 or item 2, I'm already going to say that you're mild depressed, right? So if you're reporting you feel down and depressed more days than not of the week, that should automatically be depression. Now, you may not have the other symptoms of it, and so that's something where you have to then explore and understand it. The other kind of end of the spectrum is some people will mark 3 for every single item, and they're actually doing a lot better. So it's self-report. You do have to kind of take it with a grain of salt, kind of use your own clinical intuition for it. But what's really helpful here is by knowing the severity of the depressive episode, by understanding kind of that, and getting a hint then kind of gives you, as the clinician, a way to go and what to do, because the treatment algorithm for depression actually is based on mild, moderate, or severe depression. So what you do kind of changes based on the severity of the episode. So I talked about how in the GDS-15 that some of the somatic symptoms are less focused on than, or at least they're kind of underrepresented as compared to some of the other symptoms. And why I think that's important in HIV is, again, lots of folks who have HIV have already some of these somatic symptoms, specifically sleep changes. We know that 70% of patients with HIV actually suffer from some form of insomnia. This is regardless of viral suppression or medications. It's not a specific to viral load. It's not specific to their ART. It is probably multifactorial in terms of both some of the neuroinflammation aspects of the HIV, as well as just some of the psychological aspects of having it. Decreased interest or anhedonia or guilt or worthlessness being some of the cardinal symptoms of depression. And by the way, I'm using SIGI caps. I think most of us learned SIGI caps as kind of our mnemonic for that, but it is something I kind of do go back through. And when I'm kind of thinking about this, even as a psychiatrist that's been out for a while, I still kind of look and I do SIGI caps in my head. I may not be asking it in the same direction, but I do have a mental checklist that I'm making sure I'm asking SIGI caps. So in the E or being energy, fatigue is actually really also prevalent in persons with HIV. It is the most common complaint amongst patients with HIV. So one of the most common things that patients will report is fatigue. We do know that it's more common in folks who have advanced disease, so clinical AIDS. It's also more common in patients who have comorbid depression or low hemoglobin status, which makes sense. But even in virally suppressed persons, fatigue is a very common complaint, and it can be both from the neuroinflammation of the disease as well as a side effect of antiretroviral medications. So something to think about. Decreased concentration. Again, concentration and kind of executive functioning are pretty common. This kind of gets us into the idea of HIV-associated neurocognitive dysfunction or disorder, where some people can be asymptomatic in terms of they have impairments in concentration and executive functioning, but they're not impaired in enough domains of their life that it's impacting them more than just kind of slowing them down. And then again, appetite changes, increased or decreased for depression, but obviously decreased appetite can happen in folks with ongoing HIV who are not virally suppressed, and then some antiretroviral medicines are pretty notorious in terms of causing appetite suppression or kind of decreased appetite or just feeling icky. Psychomotor status, this is increased or decreased activity. Psychomotor slowing, though, is very common in hand. The two things that we think about as being cardinal symptoms of HIV-associated neurocognitive dysfunction are bradyphrenia and bradykinesia. So bradyphrenia meaning slowed thinking, bradykinesia meaning slowed movements. So gait, finger tapping, and manual dexterity slowing are pretty common and early things that you would pick up even in the asymptomatic level. So not an unusual thing to see. And then suicidality. Suicidality is much more common in people with HIV. It's people with HIV are 100 times more likely to die by suicide than the general population. So when the geriatric depression scale doesn't ask that, if you're using that, you're still incumbent to ask that to screen for suicidality on there. So disentangling these effects, though, in depression, is this depression? Is this an effect of the disease? It's somewhat hard to know, but either way, you still should just treat it as if it's depression, because we know that just treating the depression is the most important thing. And that unfortunately, people living with HIV oftentimes are not diagnosed with depression, or they're not adequately treated for their depression. So when I think about this is actually from a journal in Singapore, but I really liked how they looked at it. So when we're thinking about the idea of depression, first off, we want to know what we're talking about, right? Is this a major depressive episode? Because the treatment algorithm and the treatment guidelines are specifically for major depressive disorder or major depressive episode. So depression, meaning just mild depression, feeling down, is somewhat different than a major depressive episode. So we want to make sure that we're actually diagnosing depression. So looking at the differential diagnosis, performing a mental status exam, performing a focused physical exam where indicated, especially palpating the thyroid, getting labs for thyroid function, things like that, assessing for suicide risk, and then thinking about other psychiatric comorbidities, substance use that could be also mimicking depression or just driving to depression. So like I said, the algorithm for us when we treat depression is based off of the severity symptoms. So for mild episodes of major depressive disorder, unless the patient has had recurrent, moderate, or severe episodes, and now we're just in another episode and we're catching it at the mild stage, absent that, if it's mild, there's not really a role for pharmacologic therapy. Mild depression has never really been shown to do well with pharmacologic therapy. And so in that case, we really should be focusing on non-pharmacologic management, specifically behavioral activation and sleep hygiene and kind of listening and being supportive in that session. I'm a really big believer that every encounter with a healthcare professional has the opportunity to be psychotherapy. And I recognize that I am not the only one that's doing psychotherapy as an MD. You guys as primary care are also doing psychotherapy simply by having good bedside manner, simply by creating a therapeutic listening space and hearing the patient out. So that bedside manner, just sitting there listening and creating that space, is supportive psychotherapy, and you're doing a lot to help them by just listening to them, validating them, and being someone that can be there. Other things you can do are kind of self-help activities. So there's plenty of evidence-based self-help programs out there. Feeling Good is probably the biggest, longest running series of CBT. It was the original book David Burns wrote, and it has tons and tons of self-guided manuals that people can use. There are apps and things like that. And then it's also reasonable at mild depression to have someone thinking about, is this referral to psychotherapy and a reasonable thing for someone, especially if we know that if we catch this early and treat it with these techniques, we can actually prevent it from progressing to moderate or severe. So you're doing a service to this patient by using these techniques. In moderate depression, the evidence is that pharmacotherapy and psychotherapy are equally as effective. And so this becomes a really big talking point in terms of when do we prescribe in the moderate depression range. And so what I will always counsel patients is that yes, psychotherapy and pharmacotherapy are equal. And if you don't want to do a medication, I'm going to go there with you. I'll walk with you. We'll do this non-pharmacologic management. But one thing that happens is we know that initiating a pharmacotherapy early decreases the length of the episode, and then it makes the psychotherapy kind of stick better. So there is a role for initiating psychotherapy or psychopharmacology early on, as well as getting someone hooked up with therapy. Now in the primary care setting, because of the lack of availability of psychotherapists, because it's going to be 6 to 9 months of a wait time, I would be more inclined to say, yeah, we need to start an antidepressant at moderate, even if we're going to go to the therapy route, just because we know it's going to take longer to get in there, and we want to actually treat the depression symptoms pretty aggressively because of the risk of not being adherent to our antiretrovirals, the risk of other things going on. And also, the longer a depressive episode goes on, the more likely it is to become treatment refractory, and the more likely it is that the person's going to have recurrent episodes of depression. So early treatment in the moderate phase is very important, but it's still at that point reasonable if the patient doesn't want to be on a pharmacotherapy regimen at that time. For severe depression, though, it's absolutely recommended for pharmacotherapy. In severe depression, the depression is so profound that no amount of the psychotherapy is really going to be able to help them in a quick enough manner to get them out of it. And we know at that point with severe depression that undertreating it is a significant risk factor for suicide. So treatment with severe range is really, I'm going to start being kind of a little bit more heavy-handed of like, you really need to be on an antidepressant at this point. The article for managing depression, this article says referral to psychiatry services. That is great in a place where you have tons and tons of psychiatric providers around. But I know a lot of you guys are probably also still managing severe depression without getting them over to a psychiatrist simply because of lack of access. So in that case, that's why I kind of want to talk about kind of my treatment algorithm and like what to do kind of initial steps. So I think you guys are all probably pretty good at first steps, but in terms of going to our next step, that's where I think people kind of falter. So there was a really, really good study in 2007 that came out. It's called the STAR-D trial. And it's the sequence treatment algorithm for depression. And so they really looked at kind of all the evidence out there, and they designed a clinical trial to see if this rational approach to pharmacotherapy actually made sense and helped people with remission. The data for it was okay, but in terms of psychiatric outcomes, it's probably one of the better, even with that okay data. It's 2007, so they started with citalopram simply because it was the number one prescribed antidepressant out there. And then they kind of had this stepwise approach of going to a different agent or augmentation or switching to things like mirtazapine, nortriptyline, stuff like that, all the way down to initiating an MAOI. I don't expect anyone outside of psychiatry to initiate an MAOI because I've only done it myself as a psychiatrist 2 or 3 times. So by getting to that point, you're really wanting to get in with psychiatry. So using this and not really being fixed with a medication, this is kind of the approach that we really should be thinking about. And this comes from our Maudsley, our European and UK colleagues. So what they're really talking about is they really want you to start a antidepressant. Any kind of first-line antidepressant is reasonable to start, and you want to titrate it to its recognized therapeutic dose. There's a really good study that looked at where primary care providers kind of faltered in terms of antidepressant prescribing, and what really we find is that it's not going to the maximum effective dose, and it's not doing it kind of aggressively enough. So rapid titration of some things is not necessarily the greatest, but pushing these to the kind of what we know to be an effective dose, and then if you're still not getting results, going ahead and pushing it to the maximum FDA dose. And in psychiatry, we'll actually go above the maximum FDA dose. So for example, escitalopram's maximum dose is 20 based on the FDA. There's tons of good literature to suggest that actually 30 can be beneficial. And so I will push people to 30 before abandoning that medicine and going to something else, just to try to keep them on that. So we've pushed them on the medication. We've got them to an effective dose, and we're going to be kind of looking for efficacy. People with anxious depression or people with irritable depression symptoms, that's actually some of the first things that'll improve. And spouses and family members oftentimes are the first one that notice that. So that's good to get collateral information. So if it is effective, that's great. We've figured out what's going on, and we want to keep it on there. Patients always ask, how long do I have to stay on these meds? The guidelines would suggest that 6 to 9 months at a full effective dose is sufficient to resolve the episode. And then at that point, you can start tapering it down if this was their first episode, if they don't want to be on the medication long term. I do have a rule here in the Pacific Northwest is if that 9 months happens around this time of year, we're probably going to go a little bit longer. I don't like taking people off their antidepressants in the middle of winter unless we lived in Hawaii. That would be a different story. But What we do know is that the more depressive episodes you have, the more likely you are to have another depressive episode. So my rule really is 2 depressive episodes, but if it's 2 or more, absolutely, we know that lifelong treatment is probably going to be required, and someone's going to need to be on it for life to prevent that recurrence from happening. If it's not tolerated, you started them on a medicine, they are throwing up, they're having sexual side effects, they feel fatigued all the time, you've gotten them to an effective dose, or even if you haven't gotten to an effective dose and they're just like, I'm not taking this medicine, absolutely switch. If, however, you've started them on the medicine and it's a little effective, so their PHQ-9 went from 20 to 15, you kind of just you keep monitoring and tweaking it as best you can and trying to get to that maximum tolerable dose. So, that's where the watchful waiting and again, trying to get them to that max dose comes in. Okay, so what if it's still not effective? What do I do? When do I do kind of an augmentation strategy, right? So, we've looked at it, we haven't switched. So at the point of not being effective or not getting traction, things like that, you have kind of 2 options. Either you ditch it and try something completely different, so switching to a different antidepressant, which can be helpful, or it's partially effective, the person is getting a little bit better, maybe we do an augmentation strategy. And the augmentation strategies really are variable. There's so many types of augmentation out there. The most common would probably be using an antipsychotic medication like aripiprazole or one of its newer cousins. But you can also use things like buspirone, you can also use lamotrigine, you could also use sometimes we'll use a stimulant, and that's all based on kind of the phenotype of the depression. But by and large, if we're going to augment, most people's first step in augmentation is going with something like aripiprazole, simply because it's got such good efficacy. This actually keeps going. So for my trainees, I actually have it keeps going down on there. But I think after you're getting to the point where you're doing some augmentation strategies or you've switched 1 or 2 times and you're still not getting any traction on this person's depression, I think that's the point where you start referring up to psychiatry so that we can sit there and kind of assess them. From a primary care setting, it is appropriate to always review the diagnosis to make sure that we are correct in our diagnosis. I think it's going through multiple different agents and you're not finding something that works. Maybe we're not looking at bog standard depression. Maybe we're looking at bipolar disorder and we're just not seeing them flip over, or we're looking at something we're missing something. So it's always good to go back and review. And so I talked about first-line antidepressants. We're not going to talk about these today. We can talk about them later. But really, the idea right now, SSRIs used to be considered this first line. Everything, it should just be an SSRI. SNRIs and atypicals have all become off-label, and so SNRIs, especially like venlafaxine, desvenlafaxine, duloxetine, are reasonable first-line options for folks as well. And then atypicals like bupropion or mirtazapine could be reasonable first-line options as well. So just because the STAR*D says you start with citalopram and then you go to bupropion next, doesn't mean you necessarily have to do it. Vortioxetine and vilazodone are 2 new antidepressants. They are reasonable first-line treatments if insurance would cover them. That's the biggest problem, is that vortioxetine and vilazodone are very new, they're very expensive. But as they go off label here in a couple of years, they'll probably be reasonable ideas to consider as first-line treatment as well.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.